All right, welcome. You're in for a doozy here, everyone. This one's going to be slow, boring, and painful. So buckle in. So this lecture is a pediatric lecture almost entirely. And in pediatric psychology, the disorders are organized into two subcategories. These categories are externalizing and internalizing disorders. Externalizing are due to outstanding circumstances. And two examples are going to be ADHD and conduct disorder. So I remember for ADHD, I think of children in school. They have a problem with being in class. So that's kind of their problem. They're stuck sitting there. However, they're hyperactive. So that's their problem. As well as in conduct disorder, these individuals have problems with authority. So authority is the external factor. So that's kind of how I remember, which is on the external. And then internal is kind of easier. You have depression and anxiety. Those are internal problems. Those are a little more obvious. And we will begin with externalizing disorders. So the family risk factors for externalizing disorders are going to be the usual suspects, all things you would see in a Lifetime movie. Maternal depression, low income, overcrowding in a home, blah 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 blah, Crimea River. Those are the risk factors. So the first externalizing disorder is going to be oppositional defiant disorder. Now, this disorder is defined by a pattern of angry, argumentative, as well as defiant behavior. And this cannot be towards a sibling. These are against strangers, maybe people in class, co-workers, whatever. And this must occur for at least 6 months with a minimum of 4 symptoms. So it must be 4 symptoms of angry, argumentative, etc. So the disorder is diagnosed primarily among school-aged children. So oppositional defiant disorder is diagnosed primarily among school-aged children. And I love this picture, so it kind of helps me remember the age at which these children are once they are diagnosed. And then once they are diagnosed, typically it will become more serious as they progress in age. Now, once again, to diagnose oppositional defiant disorder, it requires 4 out of 8 of the following symptoms, which are listed here. I'm not going to read, but they basically, they're defiant, disobedient type symptoms. And these 4 symptoms must be ongoing for at least 6 months total in order to qualify for oppositional defiant disorder. Interestingly, the treatment for ODD, oppositional defiant disorder, is not really aimed at the child itself. It's mostly aimed at teaching the parent how to deal with the child. So this is called behavioral family therapy because you're teaching the family how to behave around the child. So basically it teaches them to be clear with their expectations, closely monitor the child's behaviors, as well as rewarding positive behavior and ignoring misbehavior. So kind of like you're training a dog. You only want to reward the good behavior and don't want to acknowledge the bad behavior because that will lead it to continue. Now the next externalizing disorder is going to be intermittent explosive disorder. Now this disorder, as the name kind of hints at, it's an intermittent, so it occurs recurrently, and it's explosive, so I think explosive, I think of a blast. So these are recurrent outbursts that occur out of proportion to the environment. So if the child is in class, they may have sudden anger or rage outburst in the class. And the child must be at least 6 years of age before this is really a problem, before it can be classified. And that kind of makes sense because, I mean, that's around the age that you start going to school normally. So that's how I kind of remember the 6 year cutoff. So there's nothing that's really been proven truly effective for treating this intermittent explosive disorder. However, you can try things that will kind of bring down their energy level. So anticonvulsants, beta blockers, lithium, antipsychotics, antidepressants. These are all drugs that are designed to kind of take you from one level and bring you down a few. So that's kind of the goal of treatment thus far in these patients. Now this next disorder is going to be conduct disorder. Now conduct disorder is characterized by a pattern of rule violations, and these are going to be typically illegal activities. Now for diagnosing conduct disorder, you have the way I think of it is these individuals are cons. So conduct disorder, think cons, convicts. So they have a 3-strike rule. Once they get 3 strikes, they go to jail for 12 months. However, in order to meet that 3-strike rule, they must have committed the last crime within the last 6 months. So that's kind of a silly way I like to remember this diagnosis of the disorder. Now these next few slides are just kind of contrasting how a conduct disorder presenting in childhood differs from it presenting in adolescence. So if it presents in childhood, there's a more likely chance of this person having a poor prognosis and becoming a juvenile offender. Now, in contrast, an individual who's diagnosed during adolescence are more well behaved, they're more likely to commit less violent crimes, and overall have a more favorable prognosis and is more likely to respond to treatment. And once again, the correlations with conduct disorder are all Lifetime movie specials, so institutional living, inconsistent parental figures, paternal alcoholism. You get the idea. Now, an important risk factor here to note is the presence of ADHD. Now, a child who contains diagnosis of ADHD along with conduct disorder is more likely to develop antisocial behavior that will last into adulthood. Now, in contrast, this is decreased likelihood in an individual who only has a conduct disorder. So just note that relationship, that ADHD plus conduct disorder leads to a worse overall prognosis in the future, and they will more likely develop antisocial personality disorder. Now for treating conduct disorders, it's going to be the usual psycho mumbo jumbo. You have basically sit around, talk about your feelings. You have family therapy, behavioral management training, social skills, teaching, problem solving. Just pick the most feelingest treatment, and that's going to be the answer. Now, this is a busy slide, but I'm going to sum it up pretty easily here. So, diagnosing antisocial personality disorder requires 3 things. You must have a pattern of disregard or violation of rights of others. Number 2, they must be at least age 18. And number 3, there must be evidence of the disorder before the age of 15. So to review, they must have a pattern of behavior that is consistent with a violation of the rights of others. So that's number 1, violating rights of others. Number 2, they must be at least age 18. And number 3, although they must be at least age 18, the symptoms must be evident before the age of 15. So don't get confused there. So they must have symptoms before 15, but at diagnosis, they must be at least age 18. So the individuals who have antisocial disorder, they are egosyntonic. Thus, most of these treatments, or all treatments, are typically ineffective. There are some kind of psychotherapy with cognitive therapy, excuse me. But either way, most therapies are ineffective. Now, it's important to distinguish these disorders from one another. So to distinguish oppositional defiant disorder from conduct disorder, remember in conduct disorder, these individuals are they're convicts. So the symptoms are going to be more severe. They're going to have more aggression, and this is going to be the opposite of oppositional defiant disorder. Additionally, distinguishing ADHD from oppositional defiant disorder is based on in oppositional defiant, the individual will refuse requests in situations that are not solely when the effort is needed to sustain attention. So basically, individuals with ODD don't care if the attention is on them or not, whereas they're saying that is the case in ADHD. Now next we have pyromania. We all know what pyromania is, so I won't belabor the point. It is more common in men, and it usually begins in late childhood, usually between the ages of 11 to 15. And these individuals are more likely to commit other crimes, including forcible rape, as well as vandalism of property, which makes sense because you remember seeing them in movies as like lighting houses on fire. That would be considered a vandalism of property. Now, how males were the most common in pyromania, women are the most common in kleptomania. Now, kleptomania is the recurrent, they keep stealing. They want to steal, they need to steal. And the way I remember this is that women are always seen stealing in the movies because they want to steal clothes, right? They stick it all up in their bra, blah, 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 blah. So basically, that's how I remember that females are most common in kleptomania, whereas the men are more common for pyromania. Now, some contributing factors that can lead to externalizing include a poor temperament during infancy and childhood, or excuse me, toddlerhood, as well as some neuropsychological abnormalities. Although this is rare and not really very common. Lastly, there is a genetic association. Additionally, we also have social factors and parental styles that can lead to these conditions. So, to expand on these parental characteristics that can lead to externalizing conditions, you have coercion, and this is when a child misbehaves and the parent will just give them their favorite toy or whatever. They're positively reinforcing that poor behavior. Additionally, you have negative attention. And this is the idea that punishment can actually reinforce the behavior because you're giving that child the attention that they may actually want. Additionally, there can be inconsistency with regards to the standards and the punishments themselves. All right, so we're halfway there. The remainder of this is going to be pretty review, so we could be able to rush through this here pretty quickly. So we're going to get into internalizing disorders. As was discussed previously, internalizing disorders are emotions directed inward, which is in contrast to externalizing, which are emotions directed outward. Okay, these make sense. Now, with regards to epidemiology, it's important to note that internalizing disorders, particularly depression, has a high increase, a six-fold increase in suicide risk. In addition to suicide risk, there also is a risk of cluster suicides, especially if the children are in schools. So there's also going to be biological, genetic, as well as social factors, which is consistent with basically every other psychiatric illness. Now, the frequency of depression does increase with age, and additionally, when it comes to gender, it's equal up until adolescence, which is that time point between the ages of 10 to 19. At that point, females outnumber males up to 3 to 1 when it comes to prevalence of depression. And then the definitions are consistent across adulthood and pediatric depression, so there's no difference there. Now, the diagnostic criteria for depression is they must have a depressed mood, which makes sense, and they must have at least 5 symptoms for a 2-week period. So 5 of the 9 symptoms for a 2-week period. Now, these symptoms are listed here. I wouldn't memorize them. It seems, I mean, these all sound like depression to me. Depressed mood, that's depression. Diminished interest and pleasure, depression. When you're depressed, you eat more, so you're going to gain weight. Also, you're depressed, so you're up all night feeling sorry for yourself. These all make sense if you just think out the response. Continues here, recurrent thoughts of death, etc., etc. All make sense as to symptoms of depression. Not hard. Now, you must ensure that when you're diagnosing depression, that the diagnosis is not due, or the symptoms rather, are not due to bereavement. So they must be at least 2 months after a loss of a loved one or some other tragic event. Additionally, it cannot be coincide with a mixed bipolar episode, so it has to stand alone in that regard as well. And they use this kid's picture a lot, huh? So the symptoms, as I said, with depression are pretty self-explanatory. We don't need to go into them again. So the symptoms that decrease with age, or the better way to state this is the symptoms that are most common in children include somatic symptoms. So they'll complain of head, stomach pain, muscle aches. They'll also be more prone to behavioral problems, irritability, as well as hallucinations. So this kind of all makes sense if you think about it. These don't seem like adult complaints really, at least not to me. The symptoms that are consistent across age groups are going to be pretty obvious as well. You're going to have depression, depressed mood, obviously, impaired concentration, and then you're also going to be suicidal. And this makes sense because everyone commits suicide, and you wouldn't be depressed without depression. Now, first line treatment for depression is going to be a bunch of feeling interventions, so cognitive, CBT, interpersonal, group, family therapy. So first line is going to be a bunch of stuff dealing with emotions. Kumbaya, as you will. Now, when you start getting to medications, and that's when the symptoms are more moderate to severe depression. And before you're going to give a medication, of course, you need to weigh the risk and reward for these medications, especially since some of these medications can actually lead to suicide. Interestingly, of all the SSRIs that we've heard of, the only one that's FDA approved in children up to 8 years old is fluoxetine. Um, Now the next one up, I guess, from 12 to 17-year-olds is going to be escitalopram. So to review, SSRIs are indicated for moderate to severe depression only, and then you don't start treating until around 8 years old. Once the child is 8 years old, you can start with fluoxetine because it's the only one that's FDA approved, and then once they reach 12 years old, then you can try escitalopram, which is another SSRI. Next, we're going to be moving on to bipolar disorder. And this slide is just basically saying that there has been a correlation between people who have developed bipolar disorder in later teenage years into how they presented as children, just because parents have said that their child has showed sign in the past, may even have like temper tantrums without any prior provocation. Now, it's important to note that childhood bipolar disorder presents a little differently than the adult version. So it can be more of an insidious onset. They may not have that clear distinction between manic and depression. So just note that it is different and it can be kind of harder to diagnose, especially in the younger age. Now, as was stated in the last slide, essentially children with bipolar present more slowly and not as consistent as in adults. So they can often be confused with other more common childhood psychiatric illness. So for example, the initial depressive state of bipolar can often be confused as major depressive disorder, whereas the manic episodes of bipolar can often be confused with ADHD. And this is because children in their manic state are more likely to be irritable or prone to destructive outbursts in contrast to the adults in their manic state that are more likely to present in euphoria or appear more elated in nature. So just important to note that can be a little confusing, and it is important to distinguish the two. Again, it is important to distinguish mania from ADHD. So as you see on the slide, they're very similar. It's very difficult to differentiate the two between in children. However, there are distinguishable based on in mania in children. They will have a more elated mood, will have ideas of grandiosity, of grandeur, and they may also have a decreased need for sleep, or may actually also be hypersexual. And these symptoms do not typically present in ADHD in those manners. Now we're going to get into the pharmacology for childhood bipolar disorder. The two first classes of medications we're going to be talking about are lithium, which is, so we're going to talk about lithium as well as the anti-epileptics. Lithium is used as a prophylactic measure against mania. It is more frequently used in adults, but it can be used in children beginning at age 12. So 12 and older, you can use lithium for its prophylactic effect. Now, the next two medications are anti-epileptics. The first one is going to be Depakote. This is also called valproic acid, and this is used to control the rapid cycling between the manic and depressive phases. As well as the next medication is going to be Tegretol or carbamazepine. This one has an anti-manic and anti-aggressive characteristic to it. So if you're thinking about them, they're anticonvulsants, so they're going to be kind of slowing down those rapid fluctuations. So I think of seizures, I think of the twitching. So these are fluctuations in personality. So I think of it as a fluctuation in personality, which you could treat with the anti-epileptics as stated. Now for second line medications, so second line to lithium and or the anticonvulsants, valproic acid and carbamazepine, you have the antipsychotics. These are going to include aripiprazole, risperidone, quetiapine, which is, that one's more frequently called Seroquel, and then olanzapine. And these all kind of have the same age time point from 10 to 17, except for olanzapine, so that's the outliner, which cannot be started until 13 years of age. Okay, we're at that home stretch. We have two conditions left. The first one is going to be anxiety. Now this includes things like selective mutism, specific phobia, all the different types of anxiety, panic disorder, agoraphobia, and generalized anxiety disorder. Now you should remember pretty much all of these. The only one I'll kind of review here is agoraphobia. Remember, this is the fear of being unable to escape a situation. Now the first line treatment for treating anxiety is going to be, of course, psychological therapy. Now after that you can consider SSRIs. So the best therapy is believed to be a combination of sertraline plus CBT. So I would take your time and come back and look at this chart later. I know Dr. Levine placed an emphasis on the medications because she found them important. But basically what this slide is saying is that the majority of SSRIs are going to be used for treating OCD-related anxiety disorders. So all those medications we talked about before, sertraline, fluoxetine, those have not been approved for pediatric use of non-OCD anxiety disorder. And additionally, the two that are not approved at all for pediatric use are going to be paroxetine and venlafaxine. And just note that venlafaxine is the one outlier on this list because it is the only SNRI, except for maybe fluvoxamine. I'm not really sure what that one is. Lastly, we have childhood OCD. Now, early onset OCD typically presents with increase in tics or a tic disorder, and they also have a comorbidity of ADHD. It's important to note that about half of adults with OCD did actually have a childhood onset. So they had it some childhood to adulthood, so it's just important to note that. And then just remember the symptoms of OCD. You have obsessions and compulsions. So treatment for childhood OCD is going to be SSRIs. So just note that the only SSRI, well, the SSRI that can be used with the youngest age group, so starting at 7 years old, is going to be sertraline. So sertraline can be started at 7 years old, but also note that all these antidepressants, all the SSRIs, do contain a black box warning for suicide in this age bracket. So just something that the patient does need to be educated on. Alright guys, that was it. Thanks for sticking with me, and hope those were helpful.